Managing pain, anxiety, agitation.
Mm-hmm.
It's a constant challenge in the ICU for ventilated adults, isn't it?
Absolutely. And these things, delirium, sleep disruption, they really stack up.
Yeah, they lead to worse outcomes. More morbidity, longer stays in the ICU, even long-term cognitive issues.
And higher mortality, unfortunately. It's a serious set of problems we grapple with daily.
Which brings us to the new update from the Society of Critical Care Medicine.
Right, the 2025 update. It builds on the previous PADIS guidelines from 2018.
Based on new evidence?
Yeah, they looked at about 29 new randomized controlled trials. So solid data behind it.
Okay, so today let's unpack what this means specifically for sedation in these patients.
Sounds good. The big headline, really, is a shift in thinking about dexmedetomidine versus propofol.
Okay.
The 2025 update now suggests using dexmedetomidine over propofol in certain situations.
Which situations are those?
Specifically when the goal is light sedation, or, importantly, when you're trying to reduce delirium.
Delirium reduction. That's huge. What's the thinking behind that recommendation?
Well, the data suggests dexmedetomidine is better at preserving arousability. Patients seem more able to interact cognitively.
So less snowed under, basically.
Exactly. And there's some thought it might support more natural circadian rhythms, though that needs more research. But the key is delirium reduction.
Which, as we said, is a major driver of poor ICU outcomes.
Precisely. The analysis of those trials showed a statistically significant drop in delirium duration with dexmedetomidine compared to propofol. That could translate to fewer long-term cognitive problems down the road.
And how does it work? What's the mechanism?
It's an alpha-2 adrenergic agonist, so it targets specific receptors, mainly in the brainstem, involved in, regulating wakefulness and sedation.
So it induces a calmer state.
Yes, but a state where patients are often more easily woken up. It's potentially more like a natural sleep state compared to, say, propofol or benzodiazepines, which can cause deeper, less arousable sedation.
Okay, sounds promising. But are there downsides? Any trade-offs?
Yes, definitely. The main one clinicians need to be aware of is bradycardia.
Slow heart rate.
Right. It's a common side effect. And while often tolerated okay, it can be significant.
Who's most at risk for problems with bradycardia from dexmedetomidine?
You need to be cautious in patients who already have conduction system disease, like heart block.
Makes sense.
Also, patients already on beta blockers or those who are volume depleted or have sepsis-related vasodilation. Their hemodynamics might be less stable to start with.
So in those cases, or if you need deeper sedation, maybe dexmedetomidine isn't the first choice.
Exactly. The guidelines suggest considering alternatives like propofol or perhaps benzodiazepines in specific scenarios. Patients at high risk for that significant bradycardia we just discussed, or critically when you actually need deep sedation.
Like with paralysis.
Yes, if you're using neuromuscular blockade. Or for managing severe ARDS, that's acute respiratory distress syndrome. Or trying to control refractory intracranial pressure.
Those very critical situations where you need the patient deeply sedated and still.
Correct. In those cases, propofol or other agents might be more appropriate to achieve that necessary depth of sedation.
So the message really is that sedation has to be tailored to the individual patient.
Absolutely. There's no single best sedative for everyone all the time. You really have to think it through.
What factors should clinicians be weighing up?
Well, the target sedation depth, obviously light versus deep, the patient's individual risk for delirium, their hemodynamic stability, blood pressure, heart rate, whether you need to perform frequent neurological assessments, how long you anticipate they'll need mechanical ventilation, and potential drug accumulation or withdrawal issues. Lots to consider.
It really highlights that the fundamental practices still matter, doesn't it?
Totally. Regular sedation assessment using validated scales, doing daily sedation interruptions or sedation holidays where appropriate.
And the analgesia first approach.
Still key. Manage pain first, then sedate to the minimum necessary level. That hasn't changed.
So if we boil it down for the emergency and critical care clinicians listening, what's the main action point from this 2025 update?
I'd say it's a nudge towards using dexmedetomidine more often, particularly for light sedation and delirium prevention goals. But always with a keen eye on cardiac safety. Monitor closely for bradycardia and be ready to act if it becomes problematic.
Got it. And the ultimate goal of these refined recommendations?
It's all about delivering safe, effective, and personalized care, trying to minimize any iatrogenic harm caused by our treatments.
And improving both the immediate outcomes in the ICU and the longer-term recovery for these patients.
Exactly. Better short-term and long-term outcomes. And remember, this guidance comes from the 2025 update from the Critical Care Medicine Journal.
A really important update. So for all of you providing care in the ICU, the question becomes, how will you integrate this into your practice?
Yeah, how do you balance that benefit of potentially less delirium with the real risk of bradycardia when you're choosing a sedative for your next patient? Something to reflect on.